Following removal of the bonded provisional bridge from teeth numbers 9 and 11 and placement of Empress crowns on teeth numbers 7, 8, 9, and 11, the 62-year-old female patient received local anesthetic by infiltration in the maxillary left anterior quadrant. In the edentulous site, previously occupied by tooth number 10, there was sufficient soft tissue dimension, adequate bone quality and height, and adequate interocclusal clearance with the opposing natural dentition for placement of a dental implant. Using a number 15 scalpel blade, a mid-crestal incision was made in tooth site number 10. A minimal full-thickness flap was elevated, with careful attention to maintain the integrity of the interdental papilla surrounding the newly placed crowns on the adjacent natural teeth. A round starter drill was used at 1500 RPM to mark the ideal implant location. After initial penetration of the bone crest, a 2 mm diameter twist drill was used with copious amounts of irrigation. Preparation of the osteotomy continued as described shortly, following the manufacturer's recommended protocol for placement of a 4 mm body, 3 mm platform diameter by 15 mm length NanoTite Prevail implant. The straight collar configuration was chosen rather than the expanded collar implant design to maximize the potential to preserve the crestal bone height, especially on the buccal aspect, and to manage the smaller restorative space in the maxillary lateral incisor region. A pilot drill was then advanced into the osteotomy to the depth of the line marked on the drill. Next, a surgical guide pin was placed into the site to confirm the location of the implant position and angulation. The mesial distal crestal bone dimension measured 6 mm. A 3 mm diameter twist drill was then advanced to the full predetermined depth for placement of the 15 mm length implant treatment planned for this site. The straight collar configuration of the Prevail implant did not necessitate the use of a shaping drill or countersink. The implant package was opened. Using the certain implant driver tip, the sterile implant was picked up by engaging the internal interface of the implant hex configuration. The implant was carefully carried to the mouth and placed into the prepared osteotomy at 15 to 20 RPM. No irrigation was used during the initial placement of the implant, per the recommended protocol for placement of a NanoTite implant. The insertion torque of the implant reached 45 Newton-centimeters, the torque limit preset on the drilling unit. The implant placement tool was removed from the internal interface of the implant, and an Ostel smart peg designed for the certain internal connection was placed. An implant stability quotient, or ISQ reading of 76 was obtained, which indicated a high level of initial implant stability. Since the patient requested an immediate fixed restoration and the implant achieved the acceptable torque and ISQ values, the decision was made to fabricate an immediate provisional restoration. An appropriate sized PreFormance post was selected for use as an interim abutment. The selected post had a 4 mm collar height with a 15-degree angle correction. It was placed into the internal interface of the implant with visual confirmation of complete seating. A laboratory abutment screw was placed to retain the post. The PreFormance post was prepared intraorally with a diamond burr for adequate interocclusal clearance, optimal retention, and resistance form, as well as preparation of the finish line at the gingival margin. Interrupted sutures with a 4/0 vicryl were placed to close the soft tissue flap. A high-speed diamond burr and a white stone were used to finish and polish the post. A prefabricated crown shell was tried in on the prepared post and filled with composite resin in a matching color. An optimal emergence profile was developed within the provisional restoration. The crown was removed, contoured, polished, and cemented with temporary cement. Care was taken to prevent the material from entering the flap by not overfilling the provisional crown. No bonding was done, so the provisional crown could be easily removed. The provisional restoration had no occlusal contacts in centric occlusion, following the principles of immediate non-occlusal loading. There were no contacts in lateral, working, and balancing movements. A post-insertion radiograph was taken. Since the PreFormance post is radiolucent, the implant abutment interface could not be visualized. However, the fit of the abutment to the implant was confirmed visually prior to closing the soft tissue. The patient was given oral hygiene instructions and discharged with the fixed provisional restoration in place.